On behalf of Hospice of the Piedmont and Hospice of Randolph, welcome to the E-Series, an educational webinar series aimed at engaging our community, exploring relevant topics, and educating about ways to connect with our organization. My name is Ryan Biagini, Director of Community Engagement and Education, and I am your host. Today we continue our E-Series Conversations in Care with a conversation between CEO Trent Cockerham and Senior Medical Director of Hospice of the Piedmont, Genevieve Robleski. If you have become a regular to the E-Series, our CEO Trent Cockerham is no stranger to you. Trent joined Hospice of the Piedmont in 2013 as the organization's third CEO since its founding in 1981. Prior to joining the organization, Trent worked for 16 years in long-term care with Triad Medical Services in Yadkinville, overseeing operations and management of a statewide network of almost 2,000 long-term care beds. Most recently, he led the organization in navigating a successful merger with Hospice of Randolph. Thanks for being with us again today, Trent.
My pleasure, Ryan.
Joining Trent today is Senior Medical Director of Hospice of the Piedmont, Dr. Genevieve Robleski, or Dr. Jen, as many of her patients call her. Dr. Jen also joined the organization in 2013. As Senior Medical Director, Dr. Robleski has responsibility for overseeing the organization's clinical practice, but also enjoys engaging with and treating patients herself. Dr. Robleski's past clinical experience includes several years of successful practice in the field of hospice and palliative medicine, including 2 years of clinical practice in the pain and palliative care service at the National Institutes of Health in Bethesda, Maryland. Dr. Robleski completed an accelerated BA MD program at Lehigh Drexel University and completed her residency in internal medicine at the Medical College of Pennsylvania and her fellowship in geriatric medicine at the VA Medical Center in Philadelphia, Pennsylvania. Dr. Jen has completed other graduate medical education in acupuncture at the Helms Medical Institute at UCLA Berkeley. She maintains board certifications in internal medicine as well as hospice and palliative medicine with additional qualifications in geriatrics. Dr. Robleski is a member of the American Academy of Hospice and Palliative Medicine and is a guest lecturer on palliative medicine for High Point University's Physician Assistant Program. Dr. Robleski maintains consulting medical privileges at Wake Forest Baptist Health, High Point Medical Center, as well as in Novant Health System. We are honored to have you with us today, Dr. Jen.
Thank you.
In just a moment, we will get the opportunity to sit in on a conversation between Trent and Dr. Jen as they discuss how essential it is to understand a patient's wants, needs, and priorities in hospice care, and how the medical team supports individuals and their families. During today's discussion, if you have any questions, please type them into the Q&A section, which you will find at the bottom of your screen. We will set aside time to address these at the end of the session. You may also choose to type any additional comments in the chat section. Now, without any further ado, I hand the discussion over to you, Trent.
Thank you, Ryan.
Thank you.
Well, good afternoon, Dr. Jen. It's so good to see you.
Nice to be here, Trent.
Yeah, I appreciate your being here with me. You know, Ryan gave your introduction. You're, as we all know, here at Hospice of the Piedmont and Hospice of Randolph, you're quite an accomplished physician. But aside from all of those really wonderful accomplishments that you've made in your career, for the benefit of those who are watching today, it might be interesting to know what actually led you to become a hospice physician.
Well, you know, Trent, several years after completing my fellowship in geriatric medicine, I moved to Northeast Pennsylvania. And there I met a gentleman who was actually starting a brand new hospice. And he offered me the position of the physician. And I thought it sounded really interesting. And I thought, you know, I felt pretty good about my bedside manner. And I really enjoyed listening to patients. And I thought it was right up my alley. I quickly learned that I actually did not have the appropriate training even though I had trained in internal medicine, I had taken care of intensive care unit patients who had died. I had trained in geriatrics for 2 years. I had taken care of many frail elderly patients, but I had never been mentored in the care of the patient at the very end of life. I had never been educated in what tools a physician might have in their toolbox to relieve suffering in patients for whom life-saving treatments were no longer appropriate. And I immediately got myself to a conference. It was in Albuquerque, New Mexico. I'll never forget it. It was a small room. There were not many doctors there because it was in the relative early days of hospice. And I sat there and I listened to a number of sessions, lectures, addressing the care and comfort of patients at end of life. And I have to tell you, Trent, I was surprised at how much I didn't know and thrilled at the same time that I was being given so much information that I could take back to Northeast Pennsylvania. And I took it back and I started to use these tools. And I found so much gratification in the relief of suffering that was so palpable. I said to myself, this is my calling. This is really what I want to do.
Wow. So you described something that sounds like it was such a departure from what you had known or learned previously. Might you make a comment about that?
It's stunning to me that even as a geriatrics fellow in a program collaborating with a very fine academic institution, the University of Pennsylvania, that the actual care of the imminently dying patient was not addressed. I had no real tools in my toolbox as it pertained to pain medication or the use of medications for the relief of other physical discomforts.
Mm-hmm.
And so I think things have changed. It's been a very long time, Trent. So things have changed, but it was in the early days. And I felt like I'd been led into some secret society of physicians who really had some secret knowledge on really how to help people in a difficult situation at the end of life.
And help people live better, right?
And help them live better because, you know, hospice is not just about imminently dying patients, let's be clear. And some of the tools that I use and my colleagues use, some of the medications, for example, are used well in advance of a patient's death to provide comfort and symptom management safely and effectively. Mm-hmm. So yes, hospice is a program that certainly cares for patients well upstream of the imminently dying patient.
Right. You know, one of the things that I've talked about with many of the guests who've sat in the same seat as you over the last several weeks is that two things that really in healthcare we're really unable to fix, and that's one is aging and the other one is dying, right? I mean, both of those things are sort of medical eventualities for all of us, or eventualities in life. But in your time as a physician, and particularly as a hospice physician, have you found that the patients that you've cared for, do they have a common set of thoughts or fears maybe even, or even anxieties?
So absolutely, there are some common themes. I think we can all acknowledge intellectually that as humans, we have a finite time in living, that we all will die. This is an intellectual acknowledgement we all have. And when we attend funerals of family and friends, we feel sad, but we also feel, well, this isn't my time. And so that concept of my mortality is something that I think as humans, we're wired to put, let's say, on a shelf. It's not something I'm going to deal with today. And we don't really think about it very often.
Mhm.
If we become chronically ill, we tend to be visiting physicians increasingly frequently as the disease progresses. And with each visit, if our condition has changed, treatments are modified. Perhaps they're enhanced. New things are tried. And so we're on this path that feels like there's another tool the doctor can use if things don't go well. When the concept of hospice is introduced, this is disorienting and somewhat terrifying because we have now been, our path is somewhat changed in our minds oftentimes. We've entered a new room. We've crossed over a threshold from there was always another treatment to we've started to have limits in the number of options available. We've used all of the medications and treatments. The disease has really taken hold. And so now we cross over into a new reality, which is we actually have to take the box down and really confront the fact that we are, in fact, mortal beings. So as I said, it's somewhat disorienting because sometimes patients have been on a very aggressive medical treatment and all of a sudden, no. Many times it's been more of a gradual progression of disease, and a tipping point occurs where the physician acknowledges that I've done all I can to prolong life meaningfully, and as much as I'd like to fix the problem, we are entering a phase where maybe we should focus on other things as well as the medical treatment. Maybe we should focus on quality of life, balancing treatments versus burdens.
You know, what you cite is interesting. I think if I caught that correctly, you said something to the effect of prolonging your life meaningfully. And so the tipping point, it sounds like that you're referring to is this shift in a very treatment-oriented modality of care versus one that really aims to understand who you are as a person, what's important for you, and how we help you achieve the things that are most important in your life.
Exactly. Because when one thinks about the end of life, one thinks about what's important to them.
Mm-hmm.
The question of what was my life all about comes up. What was the meaning of my life? And are there things I need to address before I die? Mm-hmm. On many levels, emotionally, psychosocially, with family and friends, spiritually. So a person takes stock, but let me just say, as much as there's a refocusing in some respects, let me just acknowledge that in hospice, we continue treatments that are life prolonging. In other words, if someone has medications for heart condition, those medications are continued. What hospice provides is an additional several layers of support on top of the standard medical care for whatever condition one has. So what I'm trying to say, Trent, is hospice is not a program where we withdraw care. We actually add layers of support and care that a person did not have before.
Because it's focused more on this larger sort of notion of existence. It's not just the medical, physiological, or symptomatic management, but more focused on how you feel, or maybe even more importantly, how your family is feeling about how you're feeling as a patient.
Absolutely, because the family in many ways is the unit of care. The patient is at the center of that unit. But the family's emotional state, the family's ability to cope with watching you potentially decline over time, the family's reaction to you're not able to take the medications anymore. All of these things are very challenging. And that is why hospice provides a team. You know, the pain that a patient feels about leaving their loved ones, the pain that a patient might feel about a disconnect from their children for one reason or another and wanting to resolve that. These are just a couple of examples of things that create suffering and which a medication will not really address. And this is why we have a team of providers.
You know, sorry, I was going to ask, I mean, say actually, remarkably, you're talking about the pain of losing a loved one that really isn't, it's not pain in the conventional medical sense.
Right. It's not, but any emotional and spiritual discomfort will oftentimes accentuate physical pain. So we look at the person as a whole in a holistic way. And we have team members who help the physician who is mainly and focused on medical management. Certainly palliative physicians have a lot of tools in terms of psychosocial support, et cetera. But we're fortunate enough in hospice to have professionals whose life work has been psychosocial support, the social worker, and then chaplain for spiritual support. So recognizing that a human's suffering is multidimensional, hospice works to address all of those issues in a team-oriented way.
Do you think that is it sounds like you might describe that as a tremendous sort of differentiator or departure, for lack of a better term, from what we might expect to be the standard methodology of engagement within the medical system?
There are pockets of team approach in medicine in today's world. There are pockets, but it isn't a uniformly applied approach to care. And I think it's just been one of the many privileges I've had to have the opportunity to work in a team because of the reasons described. Right. I have to say that my geriatric trainings had a similar model because geriatrics oftentimes is administered in a team approach. So I was used to it before I even came to hospice and recognized the benefit. All of the team members have something special to offer.
Yeah. You know, you mentioned, if I can go back for just a moment and capture something that you said earlier, you said something to the effect of hospice is not about withdrawing care. We oftentimes say that, you know, hospice isn't the difference between curative care and doing nothing. It's about arranging your priorities in order to live a better, more fulfilling life. And can you talk a little bit about that? You know, there are things that we do treat, right? I mean, that you've treated as a hospice physician.
You know what, we treat, there are some things that we aren't able to offer, but by and large, we offer the standard of care for a variety of disease processes. And along the way, patients may have an acute event, an infection, for example. If a patient's prognosis is months and they've been living a fulfilling life in the context of hospice, we treat an infection to return them to a functionality that they were enjoying a week ago. So having said that, every treatment plan has to take into account what is it that the patient is hoping for, what are the patient's priorities, and where is the patient in the trajectory of their disease. Will the treatment affect a positive outcome and one in which they're hoping for? And is it realistic? These are questions that we have to grapple with each patient, because each one is an individual and is at a different level of function. And
Yeah.
if that makes sense.
Yeah, totally. You know, I've spent a long time in healthcare, though not as a clinician, and I've talked with many patients' families who are grappling with, or maybe even patients themselves, who are grappling with these really complex decisions of is the next series of whatever it might be, right? Is the next series of treatments that I'm contemplating, are they really what I want? Are they really, I can have them, but does it fulfill something? Does it help me achieve something that I'm looking for? And so understanding that, I think, is pretty key, right?
It is. I think it's always important to ask, what is the likelihood that the treatment will actually work?
Hmm.
And what can I expect in terms of side effects from the treatment?
Mm-hmm.
And how will it impact what I'm hoping to do with the next few months of my life? These are some questions that need to be asked when thinking about a variety of treatments.
And hospice is no different, I suspect, right?
Correct. And it brings me to the concept of what can be done. There's a lot that can be done for patients in terms of medical care. There are a lot of medical treatments available for a variety of conditions, even as a person approaches the end of life. The question sometimes, what needs to be asked really is, I know what can be done. The question is, should it be done? And whether it should be done needs to be driven by the patient's wants, needs, priorities, in the context of how effective will it be, and what will the burden be, and how will it affect my life.
And maybe even my life, my family's life.
And my family's life, because some of our patients are cognitively impaired and can't make those decisions, right?
Right. Right.
And so families are left to make these decisions, and sometimes and often they struggle.
Is it fair to say that when you first encounter a patient, that what they want at that moment might be different than sort of what they want a week from now, a month from now, a year from now, because people live varying lengths of time in hospice service, right?
Absolutely. Because when they first come onto the program, as I said, they've come from a state where they have been engaging in a lot of medical care. And they may have been comfortable with the treatments, whatever they are. The treatment for their heart condition, the medication regimen that they have to follow, for example. And so as the disease progresses, patients become less functional. What do I mean by that? A person who is able to walk, albeit with difficulty, now is limited to the chair and maybe to the bed. Their ability to eat and drink normally may be impaired. Swallowing all of those pills may be challenging.
Mm-hmm.
They may have, over the period of time where they've transitioned from having, albeit a limited functionality, a good life, because people adapt to their decline. People do. But what happens eventually is that decline comes along with reprioritization. They may have achieved some of the things that they wanted to achieve in terms of communicating with family and friends, some important things. They may have taken the last trip to the beach. They may recognize that now these things are becoming harder. And so the treatment plan changes to meet the patient's condition, the patient's tolerability of the treatment plan, et cetera.
Sure.
Does that make sense?
Yeah, absolutely. It's about how we facilitate better living. I mean, I think that's basically what you just described.
Right. And as this happens, remind ourselves that the family is observing all of this and is trying to accept that their loved one is no longer able to do what they used to do and or engage in the treatments they used to engage in. So once again, psychosocial support and spiritual support for not only the patient, but the family. I think one of the most important things for families is to feel they've done everything they could for their loved one.
Mhm.
And I think that they do. But what they can do is provide a loving presence and be accepting of the limitations that medical science has to offer at some point in the patient's trajectory.
Sure. So it leads me sort of to a next thought, Dr. Jen, and this may be a biased question, okay? So I want to acknowledge that up front. But in your time as a physician, I suspect you've seen many thousands of patients. I think it's also worth noting that one thing we didn't talk about, you're actually the daughter of two physicians.
I am.
Yeah, your dad was a
My
OB.
grandfather was a physician as well.
Your grandfather was a physician. You come from a long line of physicians.
Yes.
And so without question, you've probably heard stories in your lifetime, or at least had experience with patients who had hospice and patients who didn't have hospice. And what did the care look like on either side of that?
So when you ask me that, as a geriatrician, I'm going to focus on an example of two paths that can be taken with the advanced dementia patient. Because I've seen patients on both sides of both paths.
Mm-hmm.
Just to give a little bit of information, advanced dementia patients eventually have difficulty with swallowing. And when they start to have difficulty with swallowing, they often get pneumonia.
Mm-hmm.
And as the disease progresses, the episodes of pneumonia start to increase in frequency.
Mm-hmm.
When patients with dementia go into a hospital for the treatment of pneumonia, they oftentimes return home not quite as well as they had been before they left. What I mean is they've reached a level of cognition and they are now experiencing pneumonia, and their condition drops way down, and with treatment comes back up, but not quite to the level they were before they got that pneumonia. And families notice this. Mom's never quite the same when she comes from the hospital. And
Fixed, but still better.
Right. And as these things increase in frequency, some patients' families never have the opportunity to take a step back with the help and guidance of, let's say, the physician, to say, Mom has a condition that will actually end in death, likely from pneumonia. What would Mom want you to do the next time she has pneumonia? If Mom were here sitting with us at the table, what would she ask for you to do? Because the two paths are, we continue to go into the hospital, which is an extremely disorienting, scary, terrifying place for demented patients. And certainly if they end up in the intensive care unit, extremely disorienting and scary, painful with all the treatments. And we end up, at the end of that journey, possibly at the bedside with the physician saying, we've done all we can, and now we're going to have to focus on comfort. We need to stop the aggressive treatment. The other option is we've had that conversation before that last admission or so, and families say, you know what, Mom wouldn't want all this. Mom would want to be in her bed at home, surrounded by loved ones, and have a peaceful, natural death.
you know,
He doesn't want to suffer. We don't want to see mom short of breath, but we don't want to subject mom to what we had before. And you know what's interesting, Trent? I've seen both of those scenarios. Patients' families who have gone through the ordeal of that last hospitalization, often patients come to hospice home for the end of their lives, those dementia patients. And you can see that the family has also been through a traumatic experience.
mhm.
And they've actually studied this, Trent. They found that patients' families, loved ones who have undergone the ICU route, have a much greater incidence of depression after their loved one dies than those families whose loved ones have been in a hospice program and had a different end-of-life experience.
Yeah, you know, having had experience with patients with advanced dementia in my career, um, uh, you know, an ICU or a place that doesn't look familiar, um, any place that doesn't look familiar is terribly unsettling because they really function best to the extent they have some functionality. They function best and thrive best in a surrounding that is really familiar and comfortable to them, in spite of the fact that those familiar surroundings, the familiarity of those might ebb and flow over time, right?
Absolutely.
Yeah.
I think that for families, the acknowledgement that they've done what mom or dad would have wanted can sort of mitigate the any ambivalence they may have about, well, I want to do everything that I can for mom,
Sure.
and allow mom to actually be a person that they're advocating for
Mm-hmm.
in a different way, Trent, in a different way than pulling the reflexive trigger of we're going to call 911. It's a completely different way to advocate for a loved one.
Right. I mean, what you're describing in the non-hospice setting is sort of this, I think, this transactional form of sort of expected or maybe even reflexive care. What do I mean? It's sort of, you know, the patient presents perhaps and the system, everybody who's around the patient is focused on fixing the things that are fixable. But, you know, in hospice, we're focused on that too, but we don't lose sight of the things that truly aren't fixable. And we create a balance. Is that fair?
Absolutely. And, you know, Trent, in my early career, early training, when I was a trainee doctor in internal medicine,
10 years or so ago.
I think so. You know, I'll never forget having a patient come into the hospital and assigned to me, and I took stock of the situation, and I looked at all of his laboratory data and his x-ray, and I did some tests, additional tests on him, and gave him some treatments. And what I didn't focus on was the fact that he was so close to the end of life, but I had not been mentored or educated to really take a step back and look at the big picture. And so I did what I was trained to do, and I fixed his laboratory data. And he died several hours later. But I'll never forget that case because I think to myself, I've come such a long way from being reflexive in looking at a physical abnormality or lab test in isolation.
Mm.
Physicians really need to look at the whole picture, where that patient is in their disease process, what are their hopes, wants, what are their priorities, and what should we do as opposed to what can we do.
Yeah.
That makes sense.
Yeah, it totally makes sense. You know, I'm also reminded of a reality that physicians are human, right?
Yes, and we all, you know, yes, and we learn along the way.
Yeah. And these conversations, you know, if they're not learned, during the educational process of becoming a physician, they're at least learned or informed by perhaps experience too.
I think so. Though I think, I suspect that there is more information being shared with young physicians now about hospice and palliative care than when I was
Mhm.
in training.
But at its root, it sounds as though it's incumbent upon the patient and the family to actually begin, and maybe even the physician too, but to begin an honest conversation of, you know, this is how I'm feeling. This is what I'm thinking. This is where I think we're headed. Can we talk about this?
Right. And
Uh,
you know, I think patients get very attached to their doctors and doctors to their patients in some respects. The longer you know a patient, the harder it is to prognosticate. I don't know if you know that, Trent, but they've done studies on this. The longer you know the patient, the harder it is. Interesting.
it is. Is
And
that because physicians are themselves, incredibly optimistic?
they're optimistic. And so it's also a feeling of not wanting a patient to feel abandoned.
Yeah, right.
But the thing with hospice is the primary care physician does not have to give up their relationship with their patient because they become a hospice patient. And what they actually gain is an additional support structure to help a patient through difficult times in a very efficient way. It's hard for the busy practitioner in the office and who doesn't have access to a social worker or a chaplain at a relatively moment's notice like hospice does.
Right. Now, you know, as a physician, there are you have many tools in your toolbox, I
Mm.
suspect. A lot of different types of medications. And, along with hospice, oftentimes comes this real misconception about the use of different types of medications. Might you talk a little bit about that without going to not too much medicalese, but just to have a broad overview of that?
So I think one of the medications that we use that creates the most angst in patients are the opioids. And when I say opioids, I mean drugs like morphine. In today's world, with the opioid crisis as it's been, concerns about addiction and premature death are on a lot of people's minds. The other thing that a lot of people think is that we use morphine only in patients who are imminently dying. It's not time for the morphine yet, sometimes families will say. And let me just say this about our medical practice. As a physician, first of all, I am very interested in supporting you to live as long and as comfortably as you possibly can. The use of opioids like morphine can oftentimes be extremely helpful in the appropriate dose to relieve pain and, interestingly, Trent, shortness of breath. Patients with profound shortness of breath, given a small dose of morphine, oftentimes are able to enjoy a meal without struggling to breathe, enjoy a shower without extreme distress. This is something that many people don't know. And so what I like to say to patients, especially when they are very anxious, I like to share with them that A, we're focused on improving quality of life, and B, I've had patients on these drugs for months and months, and I can see oftentimes a complete relaxation because, oh, this is a tool that will increase my quality, but she's not giving me something that will hasten.
It's something to help me live better.
something to help me live better. And you have no idea, Trent, how delighted patients are when they realize what a useful tool morphine can be.
Mm-hmm.
It just opens the door to increased functionality sometimes.
You know, one of the things you just said sort of conjured a thought in my mind is you said, you know, as a physician, your goal is to help someone live as long as they can, but many people believe that choosing hospice care is sort of tantamount to, you know, rushing the end of life. And that's really not the case at all.
Totally not the case. And once again, I like to describe it as a robust benefit because of all the additional support in the setting of a chronic illness that we will manage the best that we can.
Mm-hmm.
So we'll continue those medicines that you need for your lung disease. And we will add maybe a little morphine. We will add some psychological support because frankly, it's a really hard thing to live with chronic illness emotionally,
Right.
and spiritually.
One of the things that we haven't talked about that I'd like to see if we couldn't talk just very briefly about, oftentimes I describe the difference between palliative care and hospice as hospice takes everything that we know about palliative medicine, which is a medical specialty, and bundles it together with a lot of really important services like services of a visiting nurse, a physician, a social worker, a chaplain, a volunteer, a nursing assistant, drugs, durable medical equipment. Is that a fair statement? I mean, you know, palliative medicine is a medical specialty, but hospice is the benefit, right?
Hospice is a program
Mm-hmm.
that affords a patient, as you said, so many services and things that they need that one cannot get in any other program under Medicare or any other insurance. So hospice is palliative care, but it's an enhanced program that provides palliative care and all of the tools that one needs to live the most comfortable life in the setting of a chronic illness, in the setting of a serious life-limiting illness.
It's palliative care plus more, right?
Plus more. It's everything you had before, but now actually we're providing more support, medications, equipment. It's a wonderful program.
Mm-hmm. So, a couple more things. What's the one or two things that have made your work as a hospice physician so very different than your work prior to working in hospice?
May I say I love my work. I mean, this has been the most wonderful career I could have imagined. The opportunity to meet people where they are, to sit with them in their home, to listen to their story, to acknowledge how difficult it's been, and to be there in very, very, very special times. I have been with patients when they died, surrounded by family, and it is just a profound experience. I have been with patients who were terrified and in a lot of pain, and I've relieved that pain and just saw a completely different person emerge. It has been a wonderful thing, and I've had the ability to work with so many wonderful professionals, nurses, nursing assistants, social workers, the chaplains, my colleagues in the medical profession. I have to tell you, Trent, it's a wonderful, wonderful thing.
Mm.
The gratification has been immense.
Yeah, what you describe is sort of what I think we all conceptualize as a true patient-centered delivery of care, right?
Yes.
So I want to be mindful of folks who are watching this in our time today, but Dr. Jen, what are one or two things that you would want somebody listening to know about hospice care and our organization?
I think we've described hospice care well in terms of the additional support, but in terms of this organization, I have to say I've had a rather long career in hospice. I feel very privileged to have been working at Hospice of the Piedmont for the past 7 years. The quality of care is exceptionally good. And I must say the culture of caring and collaboration at Hospice of the Piedmont is unparalleled. So hospice in and of itself can be a scary word, but I hope that our conversation has helped to dispel some myths about it. I hope that our conversation has given people who may be thinking that a loved one might benefit some information about the rich benefits. And I also hope that people come away from this knowing that Hospice of the Piedmont is really an organization committed to excellence, patient-centered care, and quality. I'm delighted to be a member of the team.
Well, it certainly is a privilege of mine to work alongside you, Dr. Jen. And on behalf of an incredibly grateful organization, I cannot thank you enough for spending the last 45 or so minutes with me and having this really insightful conversation. I see that our host, Ryan Biagini, has magically reappeared, which means that we are close to time or at time. But thank you.
Thank you
being
for
here
having us.
today. I appreciate it. Thank you.
Thank you.
Yes, and let me just echo you both and say thank you for allowing us to sit in on this discussion. It's been quite a rich 45 minutes. Dr. Jen, thank you for sharing with us your knowledge, your experience, your passion for the work you do in supporting the needs, wants, and priorities of the patients and families you serve. The fact that you are just one member on the team of many like-minded and similarly gifted medical providers, nurses, social workers, chaplains, etc., across both of our Hospice of the Piedmont campuses is such a gift to the patients and families of our 8-county service area we serve. So thank you for all that you do and for sharing it with us today.
Well, thank you.
I also appreciate each of you listening in with us today. We will close our current e-series, Conversations in Care, in 2 weeks on Friday, December 18th, with a discussion entitled Empowering Engagement. During that conversation, Trent will sit down with a friend of Hospice of the Piedmont to hear her story of personal engagement with the organization. Together, the two of them will discuss the empowering nature of hospice and how her personal experience has spurred her to embrace the organization's mission. Registration for that webinar is live now under events on the Hospice of the Piedmont website, and I hope you will join us. Lastly, if you have enjoyed this session and would like to share it with others, you can find this e-series webinar as well as all previous webinars on the Hospice of the Piedmont website under resources. Again, thank you for being with us today, and we hope to see you next time.